This is about a 21-year-old female married 1 year back and now presented with intermittent bleeding PV for the past 3 weeks. She had been diagnosed as complete hydatidiform mole on ultrasound, and after suction, dilatation and curettage, it was confirmed on histopathologic analysis, and she had been on methotrexate after the DNC. Here transvaginal sonography was done, and I am giving the pictures of the B mode and power and spectral Doppler. Take your time and assess properly. If you want more time, please pause the video and go back to see the images again. Within few seconds, I'll give you the findings and shortly discuss about the differential diagnosis and the final diagnosis with the follow-up. Are you ready? Let's go. The first image shows bulky anteverted uterus showing poorly defined endometrium with prominent arcuate vessels in the outer third myometrium. But on power Doppler, there was extensive flow in the entire myometrium and nothing is spared. On Doppler, endometrium is now delineated and there is no color flow and there is no vascular extension. In addition, there is large, highly allied vascular flow in the right parametrium with normally visualized ovaries. With the above findings, possibility of retained products of conception is almost ruled out with no vascular pedicle connected to the endometrium. So the differential diagnosis is either diffuse AVM or gestational trophoblastic neoplasm. If serum beta HCG is not elevated, we might think about diffuse AVM. And if it is elevated, we should think about gestational trophoblastic neoplasm. To our surprise, there was mild elevation of serum beta HCG of 765 MIU per ml with the normal being less than 10. With that background, that should be invasive mole, but the serum beta HCG should be more than 10,000 to 1 lakh. But there is just a subtle elevation of serum beta HCG level. The sonographic findings and the subtle elevation of serum beta HCG is highly indicative of placental site trophoblastic tumor. We will shortly discuss about the rare diagnosis of placental site trophoblastic tumor. It's a very rare entity of gestational trophoblastic neoplasm occurring in the reproductive age group after normal delivery or abortion or after molar pregnancy, with the occurrence of timing ranges from few days to many years. It can be hypervascular or it can be relatively hypovascular. Here giving the table detailing about the various types, size and Doppler patterns of placental site trophoblastic tumor. Please go through it in detail. Type 1 shows heterogeneous solid lesion in the endometrium, and type 2 shows heterogeneous solid lesion in the myometrium, and type 3 shows cystic pattern in the myometrium with extension into the parametrium. Its size might be unifocal, multifocal or diffuse, with its size ranging from 2 to 6 centimeters. Doppler flow might be minimal, moderate or severe, with its severity being less than 5 points in the mild one, more than 5 points the moderate one, and much more severe as in our case. If we go through this pattern, our case will fit into the type 3 PSTT, which is diffuse in pattern with severe color flow aliasing. Even though hysterectomy is the primary treatment of choice in the literature, this was not done in our patient as she was nulli gravida. She was treated by multi-agent chemotherapy. There was excellent outcome. She was on routine follow-up for almost 2 years on contraception. After withdrawal of the contraception, within 1 year she conceived. But after delivery, she had profuse bleeding PV and ultrasound revealed similar pattern with color aliasing. This was managed by embolization. At that time also, she had only mild elevation of the serum beta HCG level. CT chest and brain were normal at that time. Few weeks later, she underwent hysterectomy. Now we will go for discussion. While talking about the incidence of gestational trophoblastic disease, the most common one is the complete hydatidiform mole, which everybody knows, with its incidence being 60%. And the next common one is partial hydatidiform mole, with its incidence being 20%. The incidence of invasive mole is 15%. And of the choriocarcinoma is 5%. Placental site trophoblastic tumor and epitheliotrophoblastic tumor are very rare. Complete and partial hydatidiform moles are usually benign gestational trophoblastic disease with its malignant transformation of 5 to 20% more in the complete type. Invasive mole and choriocarcinoma are malignant types of gestational trophoblastic tumor, fast growing one they are, with highly elevated serum beta HCG level. They can be usually post-molar but can occur not rarely after normal pregnancy or after abortion, with its occurrence being few months to many years later the incidence. In between the benign and malignant types, there is intermediate type of trophoblastic tumors. One is placental site trophoblastic tumor, which was discussed in detail, and the other one is epithelioid trophoblastic tumor. That's the only trophoblastic tumor that can occur even after menopause. Many literatures might point that elevated HCG is not the criteria for these intermittent types of trophoblastic tumor. Nowadays, with immunohistochemistry, few variants are also discussed in literature, with the benign common ones being exaggerated placental site reaction and placental site nodule. Already we might be having few unnamed very rare gestational trophoblastic disease, but immunohistochemistry gives the road to travel in this entity. Nowadays the immunohistochemistry plays major role because it gives the prognosis much better than any other thing, and the choice of treatment is also guided through this. I'm also enclosing the tables published by the World Health Organization about gestational trophoblastic disease. If you have time and interest, please pause the video and go through the tables about the types and classification of GTD. You can also go through the FIGO staging and classification, and also the modified WHO prognostic scoring system as adapted by FIGO. It's very important to know about the management protocol of hydatidiform mole, and then indications for chemotherapy after molar pregnancy and the routine regimens of chemotherapy. Finally, it is pertinent to know about the follow-up of any gestational trophoblastic disease. Lastly, very important to know about the contraceptive use in gestational trophoblastic disease. The recommendations by United Kingdom medical eligibility of contraceptive use. You should not use IUCD for that. Now, this was posted as a quiz few days back. Out of the participants, Dr. Gopinath is the superstar in this quiz. Dr. Chetan Vaishnav and Dr. Kadir Baksh are the near superstars. Dr. Raghavi, Dr. Jai Chandra Bose and Dr. Lakshmi Narayanan are the singing stars in this quiz. Congratulations to all the participants. Please give your comments about your experience in the gestational trophoblastic disease if you have encountered. If you have any other queries and suggestions, it's always welcome. Thank you and take care.